Hi, I'm Dr. Tony Mork, endoscopic spine specialist, and today we're going to talk about spinal stenosis of the lumbar spine. Well, stenosis is a Greek term which means narrowing, and we can see a section of narrowing here on the right in this waterway, but that is a pretty good representation of what it looks like inside the spinal canal. Anything can cause narrowing. So a disc herniation could cause it, or bony overgrowth. Anything that causes narrowing could be referred to as stenosis. Let's talk a little bit about the anatomy of the lumbar spine. Really, the spinal cord ends at lumbar 1. And we can see here the picture, it ends there where the red arrow is. And at that point, the nerves continue, they separate and continue on as separate nerves down through the lumbar spine, exiting in the foraminal canals, going out to the buttock, thigh, and legs. The nerves beyond L1 after they've separated are called the cauda equina, the horse's tail. And that's just, you can see in the picture here, it looks similar, at least in concept, to the nerves separating below lumbar 1, going into the individual nerves as it goes on down toward the sacrum. Well, spinal stenosis in the lumbar spine can occur in two locations. Inside the big canal is the central canal, and it can also occur in the foraminal canals, which are the little side channels that the nerves actually take a pathway out of the central canal. Today we're going to talk about central canal stenosis. And here we see a picture on the right. We're looking at the back, the lumbar spine from the back. We can see that the cauda equina has got a red arrow pointing to it in the center, and it's passing through the central canal. You can see that with the kind of aqua-colored arrow. And at each level, a level means where a disc has occurred, and a nerve will come on out, so the nerves exit through the foraminal canals. So central canal is what we're going to be talking about today, and which is the source of where the nerves are before they exit in the foraminal canal. Here's just an MRI scan, sagittal view. We can see the lumbar spine from the side. We can see the cauda equina with the arrow on the top. We see plenty of space. And then we see an arrow pointing, the red arrows at the bottom, the stenosis area. And we can see how close it represents the body of water we talked about earlier. And that's a area of stenosis. I like to make an analogy to Venice, Italy. We have the large or the Grand Canal, and then at numerous places we have little smaller side canals branching off, and I refer to these as the foraminal canals. Well, the problem is one of nerve compression, so stenosis gives rise to symptoms which we'll talk about in a moment, but it gives rise to symptoms because it's narrow and what I call even an apple core deformity. So we can see the area of tightness here where the arrow is pointing to. It looks fairly similar to an apple core. Well, the incidence certainly increases with age, and it can take decades to manifest. So the nerves are not really sensitive to slow changes. So this bony encroachment into the central canal can occur over a period of decades without any symptoms. And when people come into the office, they can come in with maybe 3 to 6 months of symptoms, but it can be very severe when it's first noticed because the nerves adjust so much. So here's an example of a person with 6 months of symptoms, not very much time, but we can see the red arrow on the left pointing to the overgrowth of bone completely obscuring the spinal canal. So the nerves are getting compressed, as we see circled in the green. That little tiny sliver is the entire residual of all the nerves that go down to the legs, thighs, and feet. Very tight. And so the problem is one of nerve compression. That's what spinal stenosis gives rise to. And unlike a disc herniation, stenosis occurs slowly, oftentimes over multiple decades. so slowly that you can even see people's posture changing to accommodate the problem. Of course, it's an unconscious posture change, and it even has a name. So this would be an example of a positive shopping cart sign. If you like to go to the grocery store, or you like to go to Home Depot or Lowe's, and you like to get a cart so you can lean forward, this is referred to as a positive shopping cart sign. And the reason that people like to lean forward is because it reduces the pressure on the cauda equina, which are the nerves that have left the spinal cord. So reducing the pressure, of course, reduces the pain, but it also changes the posture, as we noted above. Well, where do you feel the pain? The pain can be anywhere, but typically it's one of four places. You can have back pain, you can have buttock pain, you can have thigh and leg pain, you can have foot pain and burning. Walking endurance is significantly reduced and just gets less and less with time. And oftentimes you need to rest when walking even short distances of a couple hundred feet. Sitting down will relieve the symptoms until you get back up and start walking again. Well, what's going on here? Why spinal stenosis does it occur? Is it something you ate? No, it really comes down to something in changing the dimensions of the spinal canal. And we can see that there's lots of space between the red lines on the slide on the left, picture on the left, and we can see lots of space on the picture on the right. So it's a space issue. If we go to the level above 4 or 5, we can see that there's significant narrowing or that apple core deformity that's starting to encroach onto the space, as we're seeing here. So not much space there on the picture on the left compared to the lower one, and we can also see more of a triangular shaped spinal canal. This would be a picture of what they call the axial view, as though a camera was mounted on the ceiling and just aiming down on your spine. But it's a dimension issue, no space. And you see just once again the difference between the two. Well, as I said, it's all about the dimensions. And if it's too tight, you're going to start to get symptomatic. In this L5S1, you could drive a truck through this. It's huge. But look at the level above. We see encroachment into the spinal canal from a symptomatic patient. So what causes this dimension problem? Well, here's an example of two water pipes. The water pipe on the left has, just imagine it's a nerve instead of water flowing through it. And the pipe on the right has had a lot of calcium deposits over the years. And as a result of the calcium deposits, the water flow or the nerve is getting significantly choked off and compressed, and becomes symptomatic at a certain point in time. Well, what accounts for the dimensions? Well, it could be a congenital issue. You can see the spinal canal on the left. Again, these are axial views. The camera's mounted on the ceiling looking down through your spinal canal. Picture on the left is more normal. It's kind of oval shaped. Picture on the right is a little bit more triangular or trephine shaped. Just congenital shape can change things or predispose. Also, developmental can occur over a period of time. So as the disc space collapses, as we all get older, the disc collapse, things inside the spinal canal can actually buckle. So we have a lining of the spinal canal called the ligamentum flavum, which we see covering the spinal cord. It lines the actual spinal canal and attached to the bone, and then kind of cushions or acts as a cushion between the spinal cord and the bone. But this gets fairly thick with age and actually can buckle. If it buckles, we can see a picture of that on the right. Again, axial view, camera looking down from the ceiling. The red is outlining the spinal cord or the cauda equina, the nerves after they've left the spinal cord. The two parallel yellow on the left is the thickness of the ligamentum flavum, and on the right we can see not only that thickness, but we see an additional thickness above it, which is buckling of the ligamentum flavum. Well, the facet joints can also hypertrophy and enlarge. As they enlarge or get overgrown, the analogy would be your finger joints. So you have joints in your fingers, and with time, sometimes the bone begins to overgrow secondary to arthritic or degenerative changes. And the only thing that happens in the hand is that you've got to replace the rings, which are easily resized. However, in the spinal canal, the facet joints, if they overgrow, grow into the spinal canal and compete for space with the cauda equina, the nerves there. So you can see here on the left the facet overgrowth. It's growing into the spinal canal, and it's actually, trying to compress the cauda equina, or all the nerves that go to your thighs, legs, and feet. So the bottom line is compression of the cauda equina. That's why spinal stenosis is symptomatic. It causes problems because it's compressing the cauda equina, the nerves that are going down to your thighs, legs, and feet after it's left the spinal cord up at L1. So if the problem is compression, what's the treatment? Well, the treatment is decompression. And how do we decompress? What are the different ways that this can be done? Well, there's one called an indirect way of decompression. Here we have a Coflex device on the left, and we have a spine, a picture of a spine on the left that's pre-operative, and then we have which shows some really narrowing of the intervertebral disc space on the back side, of the posterior side, and on the right-hand side we can see a Coflex device which is a spring-loaded device that's placed between the spinous processes and jacks the disc space open, creating some additional space inside the spinal canal. And you can see that the end plates of the vertebral bodies are now parallel and opened up a little bit more. Also, there's direct decompression, where in this case some bone has just been removed. So this is a laminectomy, where the bone has just been removed from over the spinal cord, or the cauda equina. Well, some questions are what to remove when you're doing a decompression and how much to remove. Well, the what is the ligamentum flavum as well as the bone. Both of these need to be removed to some extent. So there we can see the ligamentum flavum attached to the bone on this axial view. And here's the lamina. So if we take a small portion of the lamina, like the size of that little oval, right underneath it, or heading toward the spinal nerves or the cauda equina, is the black stripe with the ligamentum flavum. So if we're doing an operation, just say that the amount of bone to be removed is between the blue dotted lines. The white is the bone, the red is the ligamentum flavum, and the yellow is a little line there is actually the dimensions of the cauda equina, or the remnants of the spinal cord. Well, how much has to be removed? Well, enough to decompress the spinal nerves, but not enough to destabilize. When you look at this, it's not really a big distance that has to be dealt with. It's just a centimeter or maybe a little bit more than that. So it's not too much distance. Here's a picture of just showing a 7-millimeter tube, how it can effectively decompress a cauda equina, the cauda equina in this picture, by just putting the tube down and developing the space between the vertebrae. So the interlaminar space, which is the yellow arrow, is being generated by the lamina of 5 and the lamina of sacral 1. So just removing some portion of the lamina of each one and just burring away the edges, it actually is not going to destabilize because the facet joint remains intact, and also importantly the soft tissues, which we're going to talk about in a moment, are also pretty much left intact. We can see the yellow, the aqua oval, and that's kind of the idea of how much of a hole in the lamina, kind of an oval hole, is going to be developed, and then using the endoscopic burr and scope in this particular picture. Well, here we can just see the oval hole. It's going up to remove a portion of the lamina, but not the whole thing. And on the bottom, we can also see that the lamina is removed in part. Once you create a hole like this, it gives the spinal cord some extra room where the spinal cord could move over toward this area. We also see at the top of the oval hole the nerve root as it's passing out of the spinal canal, the central spinal canal, across the disc, and then out to the foot or leg or thigh. Well, if you take too much bone, you can have instability issues, particularly if a large amount of the facet joint is taken, or if you take too much of something else. And what would that be? Well, stability is contributed to by two things, the bone as well as the soft tissues. And I think that the soft tissues are oftentimes underappreciated. So don't forget about the soft tissues. In the example here, we see a sailboat with a lot of wind coming across the sail, and the mast is still intact. But if you divide the ropes that hold the stays that hold the mast up, a mast in and of itself is not going to remain stable. And it's the same in the back. You have to have the soft tissue attachments to help stability. Otherwise, you're going to end up with a fusion. And this is really the main reason that there's some papers written where it shows slightly better results if you do a fusion to support the back, the bones of the back, and keep them in place after enough or maybe too much bone has been removed from the lamina as well as the soft tissues. Now, there are similar clinical outcomes whether you decompress with or without the fusion. And so whether you do the fusion with the decompression or just do it alone, they can be similar results. But I don't recommend starting with a fusion for the following reasons. Well, cost is more, of course. Recovery time is longer with the fusion, and there are more complications, both short-term and long-term, with a fusion. Well, let's talk about fusion complications. Short-term, infection rate 1%, reoperation 4%. Long-term, adjacent disc disease occurs at a rate of 5% per year afterward. So if you're 10 years out, there's a 50% chance you're going to have some adjacent disc disease or degenerative changes. It doesn't mean you're going to have an additional surgery, but it's certainly heading in that direction. If you look at the long-term complications from all causes, it's 6 to 11%. So you got hardware in place, there's that you cannot really take out. If you don't like it, there's not much you can do about it. So I recommend an endoscopic decompression to start with. The infection rate is less than 0.1%. Reoperation is less than 1%. Long-term issues, no adjacent disc disease, no non-unions, no hardware issues. So with those kind of figures, I would say that I would do the endoscopic decompression first, and if you don't like it or it's not successful and you need to have much more bone taken, that you can always do a fusion with hardware. Just kind of a term that really is a little troublesome is minimally invasive. It doesn't mean anything. It's not well defined. However, endoscopic does mean something. Endoscopic, just due to the way that the equipment is designed, means that there's no contact with room air. Of course, this reduces the infection as well as the, I believe the scar tissue formation could be reduced considerably since there's no air contact, which is oxidative, hitting the soft tissues. And this, with typical minimally invasive tubular retractors, it is in contact with room air for the whole procedure. Endoscopic, there's constant water flow. Again, there's no air contact with endoscopic because of the constant water flow. The tube size is 8 or 10 millimeters compared with the typical Metrex or the minimally invasive tubes, usually 18 to 24 millimeters. No instability is because you're not taking that much bone away, and there's minimum soft tissue injury of the, remember we talked about the soft tissues that act to stabilize the spine, like the stays on a sailboat can actually hold the mast up. So endoscopic really refers to decompression only. And the recovery, 80% of the recovery occurs in the first 6 weeks. And here's what it looks like inside after an endoscopic decompression. We can start to see the nerve, which is between all the arrows. We can see little blood vessels on the nerve, but you can see how wrapped up it is in the ligamentum flavum as well as the bones surrounding it. So it's really compressed there, as it has been for a long time, and we can see the overgrowth of both soft tissues and bone contributing to this. Well, compare open surgery to this. This is about a 3/8 of an inch incision. That's the size for the endoscope on someone's back here in order to decompress. Since the instruments pass through the middle of the endoscopic instruments, the incision could be this small. So, my thoughts are for spinal stenosis of the central canal, lumbar spine, just decompress it to start. Thank you very much for watching. If you have any further questions, please don't hesitate to contact the office. Thank you.